So again, welcome to the part one of part two webinar, the impact of historical trauma on American Indian and health equity. And again, thank you, the Alaska Native Tribal Health Consortium for having me. Next slide. So the agenda for this hour, we're going to do, thank you, Lauren, for the introductions. We're going to cover the history, historical trauma, what works. We'll do Q&A, and then we'll wrap up. Next slide. Here are some learning objectives that I hope that everyone on here will have. So number one, having an increased knowledge of history or historical trauma amongst the Alaska Native and American Indians. Number two is how trauma impacts mental and physical health. Number three, why health equity matters and how it affects the Alaska Native and American Indian populations. And last but not least, the benefits of adopting trauma-informed practices to improve that patient engagement for cancer screenings. Next slide. I always do this disclaimer. This training is not comprehensive or exhaustive. No one or two individuals represent the Alaska Native or American Indian populations, and participation in today's session is essential for optimal learning. Next slide. I always want to start off with honoring our land. So honoring the original indigenous land, we are grateful and acknowledge that the Native peoples whose ancestral homelands we gather, as well as the diverse and vibrant Native American communities who make their home here today. Again, we are the caretakers. This is our ancestral lands, and we are just here, and we got to really make sure that we take that time, we honor it, and we respect it. Next slide. So part of that, I always like to start off with the land acknowledgement. So if you could maybe put in the chat on whose land you're on. I know I am on Wiyot Hoopa Yurok land. So I'm up here in Humboldt County, way up in Northern California, and was really excited to hear that someone knew and worked in Hoopa because it is very small. But again, it goes back to us as Native people, we're relatives. We all know one another. So that really made my day. So thank you. And so again, go ahead and put in the chat on whose land you are on. Next slide. So I always like to start with a little timeline, and we won't go over all of these, but it's very important, especially on this topic. So the colonization of Alaska Native and American Indian policy timeline. Again, like I said, I won't go through all of them, but I highlighted a few that I think it's really important and we touch on. So in 1819, the U.S. Civilization Fund Act, that forced American Indian children into boarding schools. What does that mean? That means that the government came in and they ripped away children from their homes, from their cultures, from their parents, from their communities, and they forced them into a boarding school. Again, that impact that has on not just that child, but that family, that community, and all of us as American Indian Alaska Natives. Another one I really want to point out, which is really important, is 1850, the Government and Protection of Indian Acts. And this is really important because there was a bounty out for American Indian and Alaska Natives adults. And here's a perfect example of that. In 1849, our very first governor in California, Peter Burnett, he declared a war of exterminations on Native Americans. And inside of our legislation in the state of California, it was written in our legislations, and it was authorized a 1.1 payment for the suppressions of Native Americans. So when we talk about historical history, it is written in our government. So when we're talking with some patients that come into our healthcare systems, we really need to remember the history and the trauma that those patients endured, that we as Native Americans have endured.
You can give me a call back.
Oops, go ahead, if everyone could mute themselves, that would be great. Again, we have the 1893, the General Allotment Act, and that was breaking up and privatizing reservation lands. And this is really important because the law authorized the president to break up those reservations. And this was normally common land that was owned and was done by tribes and different, and they moved them into small allotments and they forced them onto these reservations. Again, in 1975, the Indian Self-Determination and Education Act. That is really important because that allowed us as Alaska Natives and Native Americans to have a greater autonomy and opportunity for programs and services on behalf of the Secretary of State of Interior. So that is really important. And that didn't happen until 1975. Many of us here on the call were already born in 1975. So a lot of times we think that this historical trauma was so long ago, but really it wasn't. And then in 1978, the American Indian Religious Freedom Act. So again, 1978, a lot of us were already born, and that's when, again, we were forced out of our communities, our homes, and forced to assimilate to these boarding schools. We were not allowed to talk our language. We were not allowed to practice our ceremonial dances. And it wasn't until 1978 where we got that Religious Freedom Act back. So again, I just like to kind of just go over, and we could go into each one of these a whole presentation, but I just really want to go over and highlight some of them because it really is that point of that historical trauma and all these things that's been happening way back, all the way from the 1800s, all the way into the 19th, even 20th century. Next slide. And again, when we're talking about Alaska, because I know we have a lot of people here from Alaska, in 1867 to 1884, Alaska went through the department era with no civilian government. And then in 1867 to 1912, it started becoming a mining district and then a territory, and then it became a state. So with the statehood, city councils were formed in many of these Native communities, shifting that power, taking away that power from those village councils onto local governments. The federal commissions and marshals were replaced with state judges, and they were appointed by the Alaska systems when a lot of that was done within those villages. Next slide, please. So we're talking about historical trauma. So what is historical trauma? Historical trauma is a constellation of characteristics associated with the massive cumulative of trauma across generations. And that's really important. Again, it's intergenerational. That's really important. These events don't just target a specific individual, they target a whole collective community, village. The trauma is held personally and can be transmitted over generations. So again, when we're talking about trauma-informed information, we really need to take a step back and think about that patient, that individual, and all of that historical trauma that a lot of it is it's intergenerational. It's transmitted over generation through generation. Next slide. So this one is a very powerful picture for me. So today, current and generational issues affect us as Alaska Natives and Native American communities, families, and individuals. Again, it affects us as a whole, as a collective. There's no one simple solution. Historically, Native Americans have been marginalized by the government policies, sending Native American children and Alaska Native children to boarding schools where they were taught to assimilate, resulting in that displacement and extermination of many tribes, villages, and communities. There can be a feeling among Alaska Natives and Native Americans that everybody hates you. And these attitudes and conflicts are passed down through generations. So again, we're talking about that intergenerational trauma. Additionally, there are problems with the economic and political disparities as well too. Next slide. And I also want to talk about too, when we talk about that boarding schools, a lot of people, again, they think it happened long ago, 100, 150 years ago, but many of us, even many of us on this call, I know I have a lot of family members that were in boarding schools. My husband's grandma was in boarding schools. So again, it's not that far. A lot of us have that trauma. Our communities have that trauma of those boarding schools and the impact of everything it has. I know my sister's mother-in-law, her brother went missing in North Dakota when he went to a boarding school at 10 years old, and still to this day, never been found. So again, that impact, it is affecting people that are here and alive today. So I think, when that patient comes in and we're talking to that patient, no matter if it's about a cancer prevention or anything. We really need to take that time to think about that history, because what it boils down to is that distrust. So we need to understand why they might not trust us, why they don't trust that Western medicine. So we need to be able to try to help fill that gap, but understand that there is that trauma and that historical history trauma that comes along with it. This picture right here is, again, it's a really powerful picture. So if you look on to the left, you have Wounded Yellow Robe, Henry Standing Bear, and Chancey Yellow Robe. So here they are all in their traditional regalia. And then on the right, 3 years later, after they came from a boarding school, you could barely recognize them. Again, their hair is cut off, their clothes, they have to, you know, conform to Christianity. They can't practice their culture. Just many of us have children, and just think about if someone came in and ripped our children away and said, you're never going to see them again. You never know what happens to them. They are not able to live the life that they're living now. This is what happened to many Alaskan Natives and Native Americans. And you could see that transition just in the 3-year period. Next slide. And again, when we talk about that historical trauma, a lot of it is not historic at all. We are still experiencing a lot of trauma today. And a big one, which is really a huge epidemic going on right now in the United States, is the missing murder Indigenous people. And it is a huge problem. We're going to play a little quick 3-minute clip, but just a little bit about this. This to me really touches home. When my daughter was medicine girl dancing, she danced alongside and with this amazing lady who's missing. And it's just very powerful. Lauren, go ahead if you could play that clip. But I don't think we could hear it.
Sorry, you said you can't hear it.
Yeah.
Oh, should have practiced that beforehand. Didn't think about that.
There's a share screen option that includes audio, which is quite frustrating because it should just do it.
Let's see. Apologies, everyone. Share screen. What do you guys see?
We just don't see anything. I don't think a screen shared right now.
Okay. Oops.
You did get a little message that you're sharing computer sound.
Hey, Nicole, can do you let's see.
Click on share screen on the meeting bar, select program or desktop you wish to share. Select share sound in the bottom left corner.
Oh, I think. Do you see the video?
Yeah.
That a school bus drove by, saw her on the bridge naked.
She went missing in early October. Every day, the frustration of wanting some, movement to having things getting done. It's very difficult.
Now this is Emily. There's a lot of Emily around here right now.
It's an eagle feathers. This is all like beaded. We had so much fun that day. There's a great picture of her and me from that day, but I don't know where that picture is.
Particularly in reservations and village areas, there is a maze of jurisdictions, of policies, of procedures, of who investigates what. I worked with a family where for 3 days they couldn't get anybody to investigate the rape because the county, the state, and the tribal police couldn't determine who had jurisdiction.
Families of the missing or murdered Indigenous women, they need somewhere to go. And so when they go to the law enforcement, they're not thinking about the jurisdiction. They're thinking about how can we get help finding our lost relative.
Early on, there should have been a bigger search for her. And I realize it's a very remote area, but you know, Hoopa Police, Yurok Police are very small. They don't have a lot of help, right?
Quite honestly, the community and the tribe as a government is getting frustrated, and they're tired of the appearance that our Native people are not getting the attention that they see with other missing cases locally and across the country.
It's real difficult when you deal with the grandkids, and the grandkids said, "Grandpa, can you take me down the river and can we look for my mom?" I mean, what do you tell them? We're looking every day, and there's a lot of people looking. Then he says, "What happens if we can't find her?"
Emily's a beautiful person, and she needs to come home to her children.
Thank you for playing that. And again, you know, so when we're talking about historical trauma, even just, I've seen this clip probably over a dozen times and it still affects me because again, we're talking about that historical trauma and that it still is happening today. So again, it's not just historical, it's happening today. And again, that generational trauma that we see. So it's really important just to take that time and to understand that history, acknowledge it, know the truth. Next slide, please. So again, when we're talking about historical traumas and how it can affect the chronic disease disparities, you know, we got to take a closer look at those gestational stressors, those childhood stressors, like we've seen in that video, and those adult stressors, you know. So when we're talking about those, you know, that childhood stressors, you know, think about those boarding schools experiences, you know, the abuse, physical, sexual, the abandonment, the forced removal, the loss of culture and language, that all plays that impact. And then when we even go to, you know, when we're talking about those childhood stressors too, we have, you know, family members who are in prison, we have mental health diagnoses that are within that home, divorce, food insecurities. I know on my reservation a few years back, we only have one grocery store on our reservation, and it was closed down because it was rat infested. So for over a year, mind you, from our reservation, the closest town is an hour away to get to a big grocery store, to a hospital. So again, those food insecurities and deserts, those all play a factor when we're talking about trauma and the correlation with the chronic disease disparities. And then adult stressors, there's alcohol, drug use, the suicide rates. We know that that is double, if not even more, in our Alaska Native American Indian communities. Poverty, poor nutrition, racism, and then the forced Christianity as well. So again, this all go hand in hand when we're talking about cancer preventions and chronic disease disparities. Next slide. So again, that historical trauma, we have to understand that history, the truth, but the next step is that healing. So historical trauma is entirely different than consciously holding on to the past when it resides in your ancestral memory and its DNA, like we talked about, that intergenerational trauma. It results in numerous defense mechanisms, developmental malfunctions, behavioral issues, and this is scientific and it's supported in several studies. So again, we talked about that history. We talked about, the truth of it all. And now that healing portion is that next step and that next phase we need to move on to. Next slide. So when we're talking a lot about that, we need to talk and understand disparities versus equity. So disparities is going to measure the harm, whereas the equity is going to measure the progress. So when we're doing work in public health and in our health systems, we really got to remember the disparities versus the equity. Next slide. So as Alaska Natives and Native American Indians, we know we are more likely to get certain cancers compared to the non-Hispanic white people. Alaska Natives and American Indian people have a much higher rate of getting several cancers, which include colorectal, lung, liver, stomach, kidney cancers, compared to the non-Hispanic white people in the United States. And again, when we do our part 2 series, we'll go into a deeper dive into that data. And so we'll really get into that data portion of that colorectal cancer among Alaska Natives and Native American Indians. Next slide. And we need to also stop and really think about the programs, the progress, how we're doing our programs within the healthcare systems, because culture is prevention. So when we're talking about preventative care, do we have that culture piece included? Successful prevention efforts need to be able to hold on to the complex truths in the Native American communities, the realities of the historical trauma and structural violence, and the profound resilience that has allowed us as Native American people and communities to survive and thrive within these harsh contexts. Concepts such as cultural connectedness, narrative resilience, honoring those treaties, like we talked about, a lot of those policies and those treaties, the conflict resolution, truth, and the reconciliation, community empowerment, family, and the culture affinity as a concept. So we got to make sure we are working towards that Native American communities and embedding that culture for that prevention. So, any of those programs you're doing, we really got to keep that focus on culture is prevention. And again, this is a pitch I was saying before, I like to use a lot of my own personal pictures, my background. This is a picture of my daughter. So I like to embed a lot of my personal pictures into my PowerPoint slides as well. Next slide. So one way we could do is move upriver. What does that mean? To move upriver means we need to advance health equity by reducing those structural and social drivers of health equities at all levels. And that's the key. We need to do it at all levels. We just can't do it on an individual or institutional level. We got to do it across the board. So number 1, we can improve those individual social needs and network. Number 2, improve internal institutional drivers of health equity. And so again, think about this as moving upriver, moving upstream. And number 3, improving community levels of social determinants of health. Next slide. So what are social drivers, SDOH? So social determinants of health are the conditions in the environments where people are born, live, learn, play, work. And those are where you live, your social circles. Maybe an SDOH can be access to your grocery store, transportation, your job. So as providers or working in the healthcare systems, when we're asking and talking to some of our patients, we got to think about what are some of the SDOHs, what is maybe preventing them from getting a colorectal cancer screenings? Yes, we know it's due, but are there other drivers that might be affecting that person from being able to get a colorectal cancer screening? Next slide. So the role of social determinants of health on colorectal cancer screening. So we need to make sure we do these again on all levels. And I think that is a key that's missing. We might be doing it on an individual level or a societal level, but we got to make sure we're doing them on all 3 levels. So an individual social needs, the social determinants of health, and the structural determinants of health equity. So on that individual level, those social needs, we got to make sure, do we have material resources required for that long-term physical and mental health of well-being? On that community level, the underlining community-wide social, economic, and physical conditions in which the people are living, working, where they're born in. So we got to think about that at a community level and on a societal level as well too. So these are generated social class inequities in society. They are a macro level factors that impact large numbers of people, social norms, the macroeconomics, social and health policies, and the structures that shape our social hierarchy, which is that power, racism, sexism, class. So it's really important that we look at the SDOHs and the social determinants of health on all of these 3 different levels. Next slide. So how can colorectal cancer rates be lowered among Alaska Native and Native American Indian people? So again, we will do a much deeper dive in our part 2 with a lot of the data, but here are some ways. So number 1, making sure Alaska Native and American Indian people get their cancer screenings test. So we know that early detection is key. And so what are we doing? I know a lot of people think colonoscopies are the gold star, but how long does it take to get into a colonoscopy? So if we're thinking about if that scheduling is 6 months, 7 months out, maybe as a provider, as a healthcare system, you still give them a fit kit because then they still have that opportunity to turn it in and get a screening because again, early detection is key. Number 2, making sure preventative healthcare services and programs are available to the people and to quit smoking. We know smoking is linked to so many cancers and especially colorectal cancer. So if a patient comes into your healthcare settings and they are due for a screening and they are a smoker, are you offering them resources? Are you sending them, home with resources? What are you doing? Again, it's not just that preventative colorectal cancer screening, but it's also other services and programs. We got to make sure we're intertwining them, weaving them all together. So number 3, developing programs that promote healthy eating and keeping a healthy weight. And that's really, really important. Are you, have programs or resources for your cultural foods? I know for us, here where I live, salmon, making sure we smoke our salmon, we can it for the winter time. Are we drying our, canning our tannic mushrooms, our deer meat, making sure that's all dried and ready to go for the winter time. Do our people have access to those cultural foods? So that is really, really key as well. Next slide. So it's easy to feel overwhelmed by the need for cultural competency to reduce healthcare disparities, but there are things we can do to make progress towards equitable care. Providers should be aware that racial and ethnic disparities exist. So that's number 1. If you are a healthcare provider, understanding and letting that patient know that you are aware of those disparities and that they are working towards eliminating these disparities, especially while preserving the culture. Because again, that culture piece is one of the main pieces that are missing. So we could do preventive care. We could do, let them know that we're helping, eliminate these disparities, but do we have that culture aspect a part of it as well? Next slide. So as Native American Alaska Natives, we believe in using our way. Native communities have the wisdom to find a solution. Our knowledge, education, and the way of learning has been through gathering, storytelling, through song and dance, and are passed down through generation. That's how we are. So when you're thinking about these programs and these resources you're offering them, think about how can we, again, embed our culture, because culture is prevention. And again, this is how we as Alaska Natives and Native Americans learn. You can hand us a paper and tell us, but again, that distrust is going to create a barrier. And we are storytellers. That is how we learn. That's how we have Indigenous knowledge, and that's how it is passed down. Next slide. So colorectal cancer screening, what works? Next slide. So a system influence culture as prevention. And again, I'm going to say it over and over again, culture is prevention. So we could use some evidence-based interventions to increase the colorectal cancer screening rates, such as client and provider reminders, provider assessment and feedbacks, and reduction of structural barriers. And so again, when I go into part 2, I will do a deeper dive into these EBIs. I will talk about text messaging campaigns, email campaigns, using QR codes. So we'll do the deeper dive into that. But just understand and making sure we have that culture embedded into the evidence-based interventions. The community assess for social norm and change. So your small media, is that culturally appropriate? Again, maybe, using some members or some people that are in your community that you put on your flyer, that you have posters in your clinic, because a lot of times when we see people who don't look like us or that aren't Alaska Native American, we're like, again, that distrust comes in. So how can we incorporate that being more geared towards Alaska Native Americans? Partnership is really important. And we see that here, that we can't do it alone. So again, it's really important to reach out and collaborate with different partners. And again, culture as a positive message for colorectal cancer screening. I know there's a lot of myths behind colorectal cancer screening. A lot of people, I've done a lot of talking circles on colorectal cancer, and the myth is, a lot of people believe it's a white man's disease. They believe it's only men, women don't get it. So it's really important to kind of create a positive message on why they should be getting screened and the importance of it. Next slide. So again, one of them I like to talk about is reducing structural barriers. Again, we are storytellers. That is how we like to gather together. We come together in a circle, and that's how we pass down our knowledge. So storytelling has been our way of teaching and learning for centuries. So again, that's one simple thing you could do to incorporate that culture, and understanding culture is prevention. Thank you. Alaska Natives and American Indians, we are storytellers. That is how we gather, pass down knowledge and information. I was once talking to an elder, and I really like to incorporate our elders into a lot of these talking circles because they have that indigenous knowledge. We have a lot of people who, they might be the experts in Western medicine, but you have to weave it together and bring in those specialists, because they are a wealth of indigenous knowledge. Talking circles have been used as a cultural appropriate way to address some of these barriers at a patient, community, and staff levels. I know when I've done a lot of talking circles, it's really important to not just to have the patients there, but also the staff and other people from the community. So again, really doing those talking circles is one form of reducing structural barriers with culture as prevention. And those are my children on the side, and then my grandbaby on the other side. So again, I like to use my own personal pictures. Next slide. So again, I was grateful for several years to chair our California Tribal Comprehensive Cancer Coalition, and we worked with a lot of other IHS clinics, and we put together, they actually put together, not we, they put together some small media health communications that are geared towards Alaska Natives, American Indians. So again, if you could work and partner with other people and within that coalition, create maybe some small medias, have some posters of some patients or people from in the community. When you go into a clinic and a video is playing, maybe interview some people with their eye stories or survivorship. So there's ways that we could really, again, have culture as a prevention within the health communications. Next slide. So quality improvement processes, and this is really important too. Here is, I worked with I worked with American Cancer Society, California Department of Public Health, Kamal Medical Center, and really providing that technical assistance, such as quality improvement coaching to some healthcare systems. So, and collecting that data, and we will again go into that deeper dive into the data, but that data is really key and important. So creating that QI team, and that QI team might be receptionists, might be some IT people, might be your nurse managers, your CHRs, and then your physicians. So really the starting point is who can be a part of that quality improvement process. And during this, a lot of times you hear the physicians are too busy, The MAs are too busy. I was working with a big healthcare center, an FQHC, and they had about 12 different clinics. And we started doing colorectal cancer screening. And what they did is they had their IT person come in, and the medical director thought of 4 questions to ask when a patient comes in. So it was, do they have a family history? Do they have any rectal bleeding? So that medical director thought of those 4 questions. And so an MA would click on the tab, ask them their 4 questions. If they said yes, then when they went inside to their appointment, the physician would talk to them and get a little more detail and schedule them for a colonoscopy. If they answered no and they were non-compliant, that MA already went in with a fit kit. And what was really nice about this after we started this project was we were able to see that a lot of the MAs were not doing this. So the head MA was able to track with IT of who and what different pods were implementing this. So we were able to catch that. So think about some quality improvement processes. And again, working and collaborating with tribes, tribal coalitions, the American Cancer Society, national coalitions, and state coalitions. That's going to really help collect that data and improve those numbers on those colorectal cancer screenings. Next slide. So again, implementation of the EBIs and supporting activities. So really, what can you do? And again, how can you weave in that culture in these? So patient reminder systems, so what are you doing for a patient reminder? And again, we'll go deeper dive. We could talk about different ways, maybe you could do a mailer with a QR code. You could do a text messaging so they could text kit back, and that reminder kit would automatically be. What do you for the provider reminders, are you sending out a scorecard? Do you have tip sheets? So again, we'll go deeper dive on some ways that we can implement some of these EBIs and support that activities. But again, we really got to make sure that culture is a part of these activities. Next slide. So providers influence is really important, and that provider team. So it's really important. The goal here is to have culture positive messages about colorectal cancer screening. So again, making sure that the provider does maybe a cultural competency training. I know working with a lot of IHS clinics, there's a lot of rotations with different physicians. So really that cultural competency key and training is really key to have a program be successful. Trauma-informed care. So talking about that history, acknowledging that history, the truth, and now being able to move on. And we have to be able to weave Western health medicine alongside with our Alaska Native American cultures as well. Motivational interviewing, cultural coordinators. So that's really key too. So no matter if it's for prevention, for patient navigator, CHR, what are ways we can have that culture embedded into their work and scope of work? Next slide. So Alaska Native and Native American traditional beliefs and practices to health, wellness, spirituality, and healing. Again, it's really important. This is my daughter when she was medicine girl. And again, culture is prevention. So it doesn't matter if we're talking about breast health, diabetes, colorectal cancer. I know our focus here is colorectal cancer, but how can we incorporate that? A perfect example is I did a talking circle at one of an Indian clinic. And what we did was we offered 2 incentives. One, of course, we had food, we gathered around in a circle, and I facilitated the talking circle. But those patients got a $15 card for the grocery store. And so they got that for attending. Then when they turned in their fit kit, they got an additional $15. And after that talking circle, we had there was about 8 men in that talking circle, which was amazing. Then we had about half of the people turn in their fit kit on site. So they needed that. And what we found out too at the end of the month is when you're going to get more participation because they need those gift cards. And I had the medical director come up to me. She's like, I've been trying to get these patients in here for years. Some of them haven't even been in the clinic for 3-4 years. So again, poop on demand. How can we make it breaking down those barriers. Maybe a lot of patients don't have running water. How are they supposed to do a fit test? A colonoscopy, if it's scheduled 6 months out, so much could happen between now and then. Maybe someone has to raise their grandchild, or, there's so many things that could happen. And when we talk about those social drivers and those determinants of health, we got to keep that in play when we're talking and we're asking these patients to do a screening. And again, I know a lot of people think colonoscopy is the gold standard, because people will be, if my fit comes back positive, I'm going to have to get a colonoscopy anyways. But the likelihood is someone could be scheduled for a colonoscopy, but 6 months out, we don't know what's going on in their life, or if they're even going to remember to make that appointment, and if all the barriers that come along with it. So let's say, it's July, it's nice in summertime, 6 months, how are they going to get there in the winter storms? It's not going to be possible. So if we could start, even if you are scheduling for a colonoscopy, still also send the fit kit along with them, because if they could turn that back and we could catch anything earlier, that's going to save the lives right there. Next slide. So best practices. So again, overall, we need to make sure we know our history, those cultural values. Listen to the Alaska Natives and American Indians' needs. Again, if you are a physician or you're working in Western health medicine, you could be the expert, but we have to weave in our cultures. We have so many people that have an abundance of Indigenous knowledge, and we need to make sure we are bringing them in as well. And be more adaptable, more culturally sensitive, and reflective on the approaches, the materials, how you're embedding that culture to go alongside with prevention. And last but not least, bringing in the experts. I think that is really key. Again, you could be that expert in the Western medicine, but it's important to bring in those other experts that are part of that community as well. Next slide. And that is it. I would like to open it up for any questions, thoughts, comments.
Thank you so much, Selena. Really appreciate that talk. You gave some great examples. And anyone who hasn't yet, if you wouldn't mind putting your name and where you're located, organization you work for in the chat, I would greatly appreciate that. And yeah, open for any questions or comments.
I do have to agree with Lorraine Thomas that I do love culture is prevention. I've not heard that, and I think it's a very key important phrase that's great. I love that. Thank you.
Yes, thank you. And I think that's a big piece when, a lot of us were working off of grant funding, or, we're collaborating. And I think that key of culture is missing. Even maybe, if we're doing a talking circle, and maybe if we're doing colorectal one, maybe we could, work on building like a GillNet or whatever it is, how can we incorporate that culture, but yet we're talking and we're going to be learning and passing now that information about colorectal cancer, about how you could detect it early. What are some risks, so that writing them down, it's not going to get, but if we can incorporate that culture talking circle model, something like that, that's where they're going to be like, oh, okay, I need to make sure I do this. And not just for colorectal, but for breast, cervical, or any other kind of cancer screening.
I also appreciated the, what'd you call it? Poop on demand.
Yes. Yes. And again, when we give out those fit kits, when we talk, most of the people we're working with are in rural communities. I know, especially, a lot of my family members are in my community, they don't have running water. They might not have they don't have electricity. So how can we make it easier if you have CHRs? Maybe when they're out in the field, can they pick up that fit kit? Because again, some clinics might have transportation. So, okay, we got the patient there. But now if we're sending them home with the kit or a colonoscopy, how are they going to turn that back in? So again, we don't want to create more barriers. We want to tear down those barriers. So again, how can we rope in the people that we are already, that are on our team, you know, so those CHRs, those patient navigators.
I think you gave some great examples of how to use fit kits and how to implement them into current practices. Not saying that you shouldn't do colonoscopies, but there's plenty of times when it's not possible or people just don't want to do it for the reasons that Selena gave, especially travel and leaving family and getting stuck, say in Anchorage or the hub cities, so towns, I should say. So really appreciate you pointing that out.
Yeah, and also I also want to point out too, so even, you know, you might have a provider group or certain physicians that are like, colonoscopies are gold standards, you know, you could still schedule that patient for a colonoscopy. And if they can't get in for 6, you know, 4, 5, 6 months, if you send them home with the fit kit, the cost is under $30 usually, you know, even with the lab fee. So again, that cost in addition to a colonoscopy is going to be is going to save, that is an opportunity to save that person's life.
Correct. And someone mentioned in the chat as well, thinking about the current issues makes the IFOB even more necessary. And I think that's a very good point as far as screening declined during COVID. So there's a lot more people due for screening. Also, the age for Alaska Natives have been 40 for a while for screening, but the age for the rest of the population has increased to 45. So there's additional people that need screening. So I think that's a really good point. Thank you for bringing that up.
It is a really good point too. And also I know here in California, we've really been fighting a lot of legislation because let's say you're on Medicare and you get scheduled to go for a colonoscopy and that's considered preventive, but now they find a polyp, a cancerous, you know, malignant polyp. Now that patient, when they wake up, is going to wake up with this huge bill when they went in as a preventative care. So again, you know, if there's ways that, you know, and so some patients will be like, no, I'm not going to get a colonoscopy, or, you know, their insurance, they might be on like, you know, a high deductible and not even knowing too that preventative care is included. But what happens? That next step is what happens if it comes back positive. So again, making sure we have those resources and we're talking through all of these processes with that patient.
Definitely. Any other questions, comments? Thank you again, Selena. Really appreciate your talk. I hope everyone else learned a lot today. And I just wanted to put up our post poll. So if you could take some time. Let's see. It wants me to share results of the first poll.
Nice.
Post poll. Okay. And so the poll should be up. Please take time and fill it out. And also, if anyone has any comments, questions, feel free to ask while the poll's being filled out.
So I used to work in oncology hematology here at the Alaska Native Medical Center. And from time to time, we'd fly people in just for a colonoscopy. On top of that, they need an escort. They need to have 3 days. So as soon as they land here, they're running to the pharmacy, grabbing the Everflow or whatever those are called. And they're going straight to their room. And we have patient housing here on campus. And then the next day they have the colonoscopy, and then they have the next day to travel. And I've always wondered, childcare, I can't think of any job that would let me take off for 3 days to go do medical anything until recently. My current job can do that, but the other 22 jobs that I've worked, because, you know, they would not have let me do that. So I've always been amazed with with healthcare and the different advances just within the last 15 years alone, and how much easier like the fit testing, and we send out Cologuards to the different people in the Bethel area that qualify. And you know, it's just amazing to see the advances.
It is, and also too, I think, giving people an option too, you know, so do you want a fit kit, which is good for a year? Do you want Cologuard, which is good for 3 years? Or do you want a colonoscopy, you know, because you feel empowered by having that choice or those options with your healthcare as well too, instead of someone saying you have to do this, I'm scheduling you for a colonoscopy, or I'm giving you a fit kit. So being able to have an option, I think that's really important. I know at my current job with the members that I work with, is that's really important, you know, is creating that option so they could pick what they want. 1, 3, you know, 10 years. Do they want a colonoscopy? Do they want the Cologuard? Do they want the fit kit? You know, so that's empowering as well too.
Agreed. And it looks like we have a few comments. Casey Fallon said we are trying to educate our staff of how to explain how to do a fit kit and having handouts in English and Spanish.
Yes, and that's important too. And also, when I worked with a lot of other clinics, is having someone within your clinic so they could recognize that face, do a quick video in one of your exams room in English and in Spanish. So let's say when the MA is checking in that patient and they can ask these questions, you know, do you have family history, rectal bleeding, you know, any of these questions, if they say no, then they're going to get a fit kit. So while they're waiting for their physicians, because we all know there is wait times in an exam room, that they could be, you could plop in that video and they could watch how to do their fit kit right then and there. So again, we want to really think about our healthcare centers, those clinics, as a one-stop shop. We want to do as much as we can there while we have that patient there. So again, put that video in, and it's going to be nice for them to see a familiar face as well too.
True that. And then Barry Levin said in the chat, thinking about current issues makes the IFOB even more necessary. Love the ideas presented and the photos shared.
Perfect. And like I said, our next part 2, we'll go that deeper dive into the EBIs, different EBIs, into the strategies, into that data. So it will be more of data and strategies of things that we could do for implementations.
Yeah, and just to remind everyone, that next part 2 is on February 8th at noon Alaska time. So I will be sending out an invite shortly after the talk today. So, well, if there's any last comments, feel free to unmute yourself or write in the comment or in the chat. Thank you all for joining us today. It was a great turnout. Really appreciate everyone joining.
Thank you.
And thanks for all the ANTHC folks that also joined. Bye.
Selena, thank you so much.
Thank you. Thank you. Do we want to set up a time to debrief or?
Yeah, we could do that for sure.
Okay.
I have a lot of things happening today. I'm actually flying to Bethel, leaving here probably at 4 and have a meetings back to back. But would you mind maybe like Thursday or Friday?
Yep, I'm off Friday, but Thursday definitely. Yep.
Okay, let me look at stuff and I will send you an invite if that works.
Perfect. All right, you guys, thank you. This was amazing. I really appreciate it.
I apologize about the video thing.
Oh no.
I always try to practice beforehand, and I got a little flustered. So thanks, Nicole, for calling out what I needed to do.
You did
Thank you,
amazing.
guys.
I would have been crying. Like, you have no idea how well you did. You were like, okay, I'm just focused to try and get this done. I'm a little embarrassed. I'm sorry. I would have been like, this is awful. I can't do this.
Yeah, but live and learn. So, but thank you very much. And I think everyone else that's on here, thank you all for attending. And Have a great day, and I'll reach out to you, Selena, very soon.
Okay, thank you guys. Nice to meet you guys.
Yep.
Bye.
Thank you. Bye-bye.